Thank you so much. Thank you for that lovely talk, Dr. Hedlund, on extraaxial collections. And thank you, Dr. Tiniang Poussant and Dr. Huisman, for the invitation to speak. And thank you for attending this session. So in the next 30 minutes, we're going to review imaging of spinal injuries in abused children. And I'd like to start with the take-home points. The first of which is spinal fractures in infants are strongly associated with abuse. And the second is that spine screening with radiographs alone, which is our conventional way of screening spines and often the only imaging that we perform of the spines, will underestimate the prevalence of spinal injury in abused children. So let's start with this case. This is a 4-month-old who presented to the emergency room after passing out after choking on his bottle. On physical examination, there was bruising around the right ear. There was bilateral retinal hemorrhages on the fundoscopic examination. And the head CT showed this small subdural in the left frontal region and a small subdural here in the right temporal region with some subarachnoid blood. There was no parenchymal injury and there was no skull fracture. We went on to do a skeletal survey. The skeletal survey revealed no fractures. But because there was a high suspicion of abuse, we went on to do an F18 bone scan. And the F18 bone scan, and this is a posterior view, showed increased uptake within the lower thoracic spine. We then went on to do an MRI examination, and that revealed simple compression fractures of T9, T10, and T11. On the axial imaging, there was no paraspinal hematoma, so we weren't able to date these fractures. Nevertheless, we identified 3 unsuspected fractures in this child. We did a skeletal survey performed 2 weeks later, which remained negative other than the now identified lower thoracic spinal fractures. This child was diagnosed with abusive injury, was taken into custody, and 4.5 later, this child is neurologically normal with no neurological deficits and no spinal deformity or pain. So this case highlights the fact that spinal injuries are easily overlooked on radiographs, and it shows you the value of additional imaging. In addition, in this child, the only fractures that were identified were spinal, and were very helpful in establishing the correct diagnosis for this child. What is the demographics? Who are the children that are affected by spinal fractures? Well, they're young. They're infants and toddlers. 2/3 of these cases will be less than 3 years of age, and half of all children with spinal fractures will be less than 1 year of age. The incidence, based on large studies of radiographic examinations, ranges from 0 to 3% of all skeletal fractures identified in the setting of abuse. Most commonly, they're identified in children that have other fractures on the skeletal survey, but in approximately 1/4 of the children, the spinal fracture was the only fracture identified. In addition, spinal fracture is highly associated with head injury. The diagnosis of spinal injury in these young children can be very challenging for a number of reasons. First, the history that's provided to the clinicians in the emergency room are often not accurate. It's very rare for a parent to come in and say, "I injured my child." Typically, because of the age of the children, they're going to be pre-verbal or they may be neurologically compromised if there's abusive head trauma. Attention may be diverted elsewhere to more obvious injuries. And in addition, the physical examination is typically unrevealing, as is the neurological examination. And as we discussed, spinal imaging is often normal. The clinical presentation is variable. Most of these children will show no signs or symptoms at all related to the spine. Occasionally, you might see a accentuated kyphosis on physical examination, or you might see some swelling over the back, and sometimes these children will have an abnormal posture or stiffness, and rarely they have signs of myelopathy. The mechanisms of injuries that are proposed are based on confessions by perpetrators. The most common is the shaking of the infant, in which the torso is held and the child is shaken back and forth, subjecting the upper spine to hyperflexion and hyperextension injury. There may be a blunt force loading injury where the child is forcefully sat down on a dressing table, or the child may be thrown and land such that there's direct impact to the spine. And then in several cases, it has been hypothesized that a child may be actively flexed or hyperextended by the perpetrator. The outcomes are variable. In the most severe cases, the injury can result in paresis, paralysis, or sometimes there may be a fatal outcome. In mild spinal injuries, they often go undiagnosed, and if they're clinically, if there's no instability, they're often resolved with no clinical result. And clinically significant spinal injuries with instability may result in ongoing back pain, repetitive injury to the spine and the spinal cord, and spinal deformity. At this point, let's go back and review some of the basic development of the spine, just so that we better understand some of the injury patterns that we see in young children. So early in life, the subaxial spine is composed of 3 ossification centers. Centrally, we have the body, which is flanked by the 2 neural arches. These are united by synchondroses, and synchondroses are cartilaginous joints that go on to ossify with time. The synchondroses fuse from posterior to anterior. So posteriorly, the synchondrosis fuses at approximately 2 to 3 years, and anteriorly, they fuse at about 3 to 6 years, so beyond the age of which we typically see spinal injuries in abused children. This is what the neurocentral synchondrosis looks like on CT. So they're thin, they're well-defined, they're lucent, so they can be mistaken for fractures. In addition, there are points of vulnerability in the spine, so they're also vulnerable to injury. We have secondary ossification centers along the anterior aspect of the transverse foramina, as well as at the tips of the spinous processes. The vertebral body itself has 4 growth plates. So we have the 2 neurocentral synchondroses that you can see here, as well as a growth plate along the inferior and superior aspect of the ossification center. That physis is capped by the ring apophysis, and the ring apophysis, as depicted here, is closely attached to the disc by Sharpey's fibers. Now, if you look at the lateral cervical spine on radiographs, you can see that a large portion of the spine is radiolucent, and that is composed of these growth plates and the disc bases. And that composition of the developing spine is not immediately evident on our sagittal T1 or T2 weighted images. However, if you do gradient imaging, that composition becomes very apparent. So here you can see the ossification center, which is dark on the T1 weighted image, and then flanked by the hyperintense growth plates and the intervertebral disc base. How do we evaluate these children for injury? We do high-detail skeletal surveys. If there's an equivocal finding or there's a high suspicion of abuse, we follow this up in 2 weeks. That gives us an additional yield of fractures in about 15% of cases. And then other imaging modalities, such as bone scan, CT, and MR, are generally reserved for problem solving. What are the patterns of injury that we see? In a spectrum from mild to severe, we see compression fractures. Typically, these are going to be simple compression fractures. They can be single or multiple, and they can be contiguous, but they can also be non-contiguous. So you want to look beyond an immediately obvious spine fracture. At the most severe end of the spectrum, we have the fracture dislocations. Typically, that's associated with spinal cord compromise. And in the middle of the spectrum, you can see injury through the synchondroses or physes. Most commonly, the vertebral body is affected when there is a fracture. Isolated posterior element fractures are rare, such as traumatic spondylolyses. The most common location is the lower thoracic spine and the thoracolumbar junction, less common cervical spine and sacrum. So this is a 6-month-old who was abused, presented with respiratory arrest. These were the spine images from the skeletal survey. And you can see a mild compression fracture of the T10 vertebral body. Because of this, we went on to get an MRI examination of the spine. That nicely identified that vertebral body fracture of T10. But if you look beyond, you can see an additional fracture at T3. Going back and looking at the radiographs, that fracture could also be identified, which was not picked up prospectively. If you take a closer look at the configuration of that compression fracture on your lateral radiograph, you don't get the greatest resolution. You get a much more better appreciation of the configuration of the spine on the sagittal reformatted image off the CT examination, and you can see this anterior loss of vertebral body height, sort of with a fish mouth deformity of the anterior aspect of the vertebral body. A similar appearance was reported in the literature in a 16-month-old child, and this is a postmortem radiograph and a photomicrograph. The photomicrograph shows the fracture between the vertebral body and the growth plate, and then cutting out inferiorly along the anterior aspect of the end plate. So this is a fracture similar to a Salter type 1 injury, where only the small bony fragment will be apparent on radiographs or CT. This is a 6-month-old child who presented with respiratory arrest. The skeletal survey was positive for multiple fractures. There was no retinal hemorrhage. The lateral plain film was read as normal. In retrospect, you can make out a little double density there, nothing you would identify prospectively. This is the MRI examination with some loss of height of the C4 vertebral body that was interpreted as a simple compression fracture. On the CT, and you can also see an additional fracture here at C7, not apparent on the radiograph. So again, an additional yield of 1 fracture on the MR. This is the CT examination, and you can see this double density that we also saw in the lateral radiograph. The axial images better explain the injury type pattern. This is a normal axial image on the right, and here you can see that there's been fractures through both neurocentral synchondroses and the physis posteriorly with displacement of the bone fragments. The vertebral body is displaced posteriorly into the central canal, giving rise to this double density. At the more severe end of the spectrum, we have the fracture dislocations. This is an old case from the literature, but it's very informative. So this was a 3-month-old who was presented to the emergency room with upper respiratory tract symptoms. She got a chest x-ray for rule out pneumonia, which showed rib fractures. Because of that, she had a skeletal survey, which showed the cervical spine injury. So she has a severe injury here with a spinal cord compression. Of note, she had no neurological deficit on her neurological examination, and she had a normal brain MRI examination. Because this child had an identical twin, that child was brought in for assessment. That child also had a normal neurological examination, got an MRI examination that showed a nearly identical fracture. So it's important. This case is important for 2 reasons. One, that even in the setting of severe spinal cord injury, the examination may be normal. And in addition, in both children, the heads were normal in appearance, which makes you wonder about the mechanism of injury. So perhaps these children were intentionally flexed or hyperextended, or perhaps the child was held by the head and the body was swung. Moving on to injuries of the lower spine, this is a case that was sent to me by Tim Higgins, one of our former fellows who's now at UVM. This was a 1-year-old abused child who came in hemorrhagic shock and retroperitoneal hemorrhage, and you can see an abnormal appearance of the lateral radiograph of the spine. And at first appearance, you might wonder if this is a traumatic spondylolysis, but it can't really be that, right, because there's no lysis through the pars interarticularis, and it looks somewhat like a subluxation, but it really can't be that either, because even though the vertebral body is anteriorly displaced, the posterior elements are normally aligned. So again, on the axial images, you can see what kind of injury this is. Again, it's a fracture through both neurocentral synchondroses and the posterior synchondrosis with anterior displacement of the vertebral body. Looking again here, now you can see that these are the neural arches superimposed with the dissociated vertebral body displaced anteriorly. And in the literature, this has been termed a wandering vertebral body. Note that if you have this kind of arrangement, that you're also going to have fractures. You can assume that they're fractures through the growth plates, right? Because there has to be some disassociation, and the weakest point is usually the interface between the vertebral body and the growth plate. Now, once you've established that there is trauma and that this is likely child abuse, the clinicians will want to know, can you date this injury? And with careful scrutiny of that lateral plane film, I think you can make out the irregularity along the posterior aspects of the spinous processes. This is what it looked like on the sagittal reformatted image, and you can see, again, the irregularity of the posterior elements. On the axial images, you can see that that represents mineralization or ossification with the paraspinal soft tissues. So this is a nice example of myositis ossificans. In addition, if you look at the remainder of the spine, you can see additional vertebral bodies showing notching and that fish mouth deformity indicating additional areas of compression fracture of the spine. Now, when a child suffers a loading injury and is forcefully sat down on a flat surface, often there is a hyperflexion component to that injury, and that can result in traction from the supraspinous ligament on the posterior elements of the spine, and that can result in avulsion injuries of the posterior of the spinous processes. If bone is avulsed, that may be apparent on your radiographs, but if it's just the cartilaginous cap, that will be radiographically occult. This is a different child which had such an injury. This is an autopsy radiograph showing multi-level avulsion injuries of the spinous processes here. This is another child that we were working up for abusive spinal injury, and we saw this increased uptake at the thoracolumbar junction posteriorly. We went on to do CT. The CT was negative. We went on to do an MRI examination, and that showed paraspinal soft tissue injury. Moving on to cervical soft tissue injuries. This was a 4-month-old who was unresponsive with respiratory distress. The head CT showed evidence for abusive head trauma. There were bilateral retinal hemorrhages. There was no skull fracture, and there was 1 CML. The lateral radiograph was read out as normal. The lateral CT examination showed no evidence for injury. And then the sagittal MRI examination that was obtained because there was intracranial injury showed this posterior layering subdural collection within the posterior fossa, as well as evidence for soft tissue injury of the deep cervical soft tissues and anteriorly within the at the craniocervical junction. So 2 papers came out this year looking at the incidence of soft tissue injury of the spine in children with accidental and abusive head trauma. And there were similar results in both the recent reports. And what these authors found is that cervical spine injury is quite common in children with accidental as well as abusive head injury, seen in 36 to 78% of children. And most of these injuries were soft tissue in nature, which means that we will not identify this injury if we do radiographs or CT examinations. You have to do the MRI to pick up these injuries. They also found a strong statistical correlation between the presence of moderate to severe head injury and the presence of cervical spine injury. So that means that if you are examining a child that has evidence of abusive head trauma, you want to move down and at least image the cervical spine in that same exam. This is a 3-month-old child who presented with seizures, had multiple bruises on physical examination and evidence for head CT, had bilateral retinal hemorrhages. The skeletal survey was normal, and there was no evidence for myelopathy. This plain film was normal. We went on to do an MRI examination of the spine because of the head injury, and that revealed abnormal signal within the interspinous ligaments posteriorly, as well as spinal cord injury. And this is an important constellation of findings to recognize because it's common in young children. This goes under the name of SCORA, which stands for spinal cord injury without radiographic abnormality. This term was coined by Ping and Wilberger in the early 80s, so it preceded the MRI era, and it related to children that had evidence of spinal cord injury but negative imaging. It's not uncommon. It's estimated to occur in up to 65% of children with spinal cord injury, It's more commonly seen in young children, and it's typically observed within the cervical region rather than the thoracic spinal cord. And most importantly, delayed onset of symptoms of myelopathy is not uncommon. And this is of importance for the ED physicians and the neurosurgeons as a reason of medical legal exposure. And it's important in child abuse because it means that the initial examination that's performed in the emergency room may not reveal signs of spinal cord injury that may become apparent on day 1 or day 2 after admission. And at that time, the child may be sedated or the arms may be immobilized by various IV lines. Finally, I would like to end with this case. This case really synthesizes some of the injury patterns that we've reviewed. This is a case that came to us recently from a tertiary care center as a consultation to our genetics department to rule out FOP, which is a rare genetic disorder known as fibrodysplasia ossificans progressiva. So this child was brought to the emergency room by the parents with respiratory difficulties and decreased movement of the arms and legs. Past medical history was negative other than for easy bruising of the face, arms, and fingers. Imaging showed this large soft tissue mass within the prevertebral soft tissue. This child was diagnosed with a presumed malignant mass, probably neuroblastoma or possibly a rhabdomyosarcoma. The child was brought to the OR and this large soft tissue mass was resected. The path came back as no evidence for malignancy. And what they did see was some osseous bone formation. And because of the surprising pathology result, the pathology was sent out for a second opinion, and the experts raised the possibility of FOP. Because of that, a skeletal survey was recommended, and the skeletal survey showed multiple fractures of the ribs on the left. Eventually, the genetic testing came back negative for ACVR1 gene. That's a gene responsible for FOP. And it should be noted that fractures are not part of the spectrum of findings in FOP. So eventually, this child was diagnosed with child abuse, and papers were filed with DCF. If you go back and look at this imaging now with the benefit of hindsight, let's look at that spinal abnormality again. I think this looks very much like that other case that I just showed you with a fracture dislocation of the cervical spine. You can also see that the posterior elements of the spine are not properly aligned. Once you're thinking along the lines of trauma, then it becomes obvious that the prevertebral mass is really a hematoma that's starting to organize and calcify, hence the pathology of myositis ossificans. With careful scrutiny, you can see a hematoma within the posterior aspect of the spine, as well as end plate irregularity of the upper thoracic vertebral bodies. At the time of initial imaging, this child also underwent a CTA to look at the involvement of the cervical arteries by the suspected mass, and that showed the fracture dislocation of the cervical spine, the calcium or bone formation within the myositis ossificans, as well as additional fractures of the lower thoracic spine and myositis ossificans lower down. The axial images of the spine were also notable for bilateral fractures of the ribs. And so I think this case really highlights how difficult it is to make this diagnosis of abusive spinal trauma or abuse if you're not thinking of it and you're not familiar with the various injury patterns. So in summary, the true incidence of spinal injury in cases of abuse is underestimated, and bone scan, CT, and MRI will increase the detection and help characterize injury patterns of bone and soft tissues, and one should have a low barrier for recommending supplemental imaging for the detection of spinal injury